5 minutes. Are any people missing, or should we start? Or yes? Okay. Okay, so this morning I talked to you about ventilation modes, and it's important to know which modes are out there and how you should use them, but I'm going to try to convince you that actually the modality is not that important. It probably is the strategy behind the mode that's important. So the ventilation strategy to make the ventilation period as lung protective as possible, because all mechanical ventilation will damage the lung. We're just going to have to try to make it as small as possible and to reduce ventilation time as much as possible. So to avoid any mistakes, we would try to avoid ventilation as much as possible in our unit also. So all babies born prematurely are, if possible, supported by nasal CPAP, but only if the baby fails nasal CPAP, then we would intubate the baby and start ventilation. And at that point in time, when we start ventilation, we have to acknowledge the fact that although BPD is a multifactorial disease, ventilation and lung injury by ventilation is still considered an important risk factor in development of BPD. And if we want to understand the mechanisms behind this, we have to go back to the animal literature. And there are several important mechanisms, important risk factors that actually can cause lung injury in our babies. And the most important one is what we call volutrauma. These are studies done in preterm lambs where they ventilated the lambs with RDS with increasing tidal volumes, 5 to 20. And then they measured the amount of lung injury expressed here as the protein leakage in the alveolar lavage fluid or the compliance at the lung. And it's clear that with increasing tidal volumes, you will get lung injury expressed here in these parameters. And we know from other studies that it's not the pressure that's causing the injury, but it's the volume that's causing the injury. And this is something that is really important to realize. Don't be afraid of higher pressures as long as you're in control of the lung volume. Another important aspect is what we call atelectrauma. So the presence of atelectasis is also injurious to the lung. Again, studies done in preterm lambs ventilated with 0 PEEP or ZEEP and a PEEP of 4. And again, they measured these parameters of lung injury, showing that if you apply positive end-expiratory pressure, stabilizing the alveoli and saculi at the end of expiration, reducing atelectasis, this will attenuate lung injury in these animals. And it's important to realize how this works, the atelectasis. I guess most neonatologists are aware of the fact that if you use high tidal volumes, this can be injurious to the lung. But I'm not sure we're all aware of the fact that atelectatrauma is a very important, maybe the most important part of lung injury. And I have 2 videos to show you how this works. So what they did in this study is they took an adult pig, made it surfactant deficient, and put a high resolution microscope on the pleural surface. And you see here an identical area of the lung, and these round structures here are the actual alveoli. And then they ventilated these pigs either with an optimal PEEP or a low PEEP. And I'm going to show you these videos separately. I can't show them in the presentation, so I have to switch. First, we're going to look at what happens if you ventilate these alveoli with an optimal PEEP. So what you can see is there's an inspiration phase and an expiration phase, and you see these alveoli, they remain open during both the inspiration phase and the expiration phase. And the other thing you should realize is that the size in which they increase the size with inspiration and expiration is really pretty modest. Just to show you again. See, so this is the area I would like you to focus on. We're going to switch to the next video, and then we're going to use a low PEEP setting. So what you can see now here is two things. First, you can see there is tidal recruitment. The alveoli collapse during expiration and reopen during inspiration. And look at the ones that remain open. They are changing in size much more than during an optimal PEEP setting. And this illustrates the two important things of atelectic trauma. The repetitive opening during inspiration and collapse during expiration is causing injury to the lung. And the second thing that you see is that the tidal volume that is entered the lung is only going to the parts that are open and remain open, and they will get a higher tidal volume. So it's a redistribution of the tidal volume you are measuring at the Y-piece. So in other words, if you set a tidal volume of 6 mL per kilo at the Y-piece, and you as a neonatologist think that's safe, this might be safe if there's no atelectasis in the lung, because the 6 mL is distributed across the total lung, and each lung unit will receive 6 mL per kilo. However, if 50% of the lung is atelectatic, then this 6 mL only goes to the other 50%, and they will get 12 mL per kilo. And this is regional overdistension. So the message here is you can set a relatively low tidal volume at the Y-piece, but if you do not have a recruitment of the lung or take away the atelectasis, even 5 or 6 mL per kilo can still cause volutrauma at the regional level. And this is something that neonatologists are not always aware of. Another thing is we know that if we add oxygen to injurious ventilation, it will also increase the amount of lung injury, as shown in these piglet studies. And the way that the lung responds to high tidal volumes or atelectasis and the amount of injury you get also depends on the condition of the lung. For instance, if you apply high peak pressures to a healthy lung, you will get some lung injury. But if you apply these same pressures to a surfactant deficient lung, you will get much more lung injury. So the surfactant condition of the lung when starting injurious ventilation determines the amount of lung injury you get. The same is true if you have a pre-inflamed lung, either antenatally or postnatally. And these are studies in preterm lambs that were exposed to endotoxin before birth. And you can see here we have control endotoxin with or without ventilation. And it's clear to see that if you combine endotoxin with ventilation, you get a much more increase in the inflammatory response compared to just ventilation alone or just endotoxin alone. Same goes for postnatal inflammation. Rabbits now, again, LPS injected. Control, just mechanical ventilation, just LPS, or the combination. And it's clear to see that if you combine LPS with injurious mechanical ventilation, you will get a much more augmented inflammatory response. So it means that it's important what the condition of the lung is. And especially in our babies, we know that they're often surfactant deficient. They're often exposed to chorioamnionitis, so an inflammatory response. Or many of our babies that actually do fine in the first week get intubated because of a sepsis, systemic inflammatory response, which will also cause an inflammatory response in the lung. And then we start ventilating these babies, and if we're not careful, we can cause lung injury even after the first few days of life. So the problem is that once you have a baby with respiratory failure, you need to ventilate this baby. You're causing injury with edema, inflammation, surfactant inhibition. You get stuck in this circle. And the thing we want to do with lung protective ventilation is try to avoid or minimize this pathway from mechanical ventilation to lung injury. Now, if we know what's causing lung injury, we can also figure out what we should do, what our strategies should be during ventilation. We should try to recruit all the collapsed alveoli because we don't want any atelectasis present. If we have recruited these alveoli, we need to stabilize these alveoli during both the inspiration and the expiration phase. We should prevent end-expiratory overdistension by using the smallest possible pressure amplitudes or tidal volumes, and if possible, reduce oxygen concentration as much as possible. Now, all of these factors together is what we call optimal lung volume on open lung ventilation. And this is the ventilation strategy to minimize lung injury independent of the ventilation mode. Now, the mode that's been most associated with lung protection in neonatology has been high-frequency ventilation. So, just a basic scheme how it works. We normally ventilate the babies with a mean area pressure or a continuous descending pressure, which opens up the lung and keeps the lung open. And on top of this, we have these very high-frequency small pressure amplitudes, resulting in very small tidal volumes. So, just by hooking up your baby to an oscillator or a high-frequency ventilator, you will get the small tidal volumes for free. You don't have to do anything. They're about 1-2 mLs per kilo, which is extremely low compared to tidal conventional ventilation. Now the question is, are these small tidal volumes enough to limit or reduce lung injury when you put a baby on a high-frequency oscillator? And this is a question some researchers try to answer with a rabbit model. These rabbits were ventilated with 100% of oxygen. This is the PO2 on the y-axis and time on the x-axis. You can see they're healthy. 100% of oxygen will lead to a very high PO2. They then washed out the surfactants, creating a lot of atelectasis, and you can see that the PO2 drops dramatically, despite the fact that they're ventilated with 100% of oxygen. They then recruited the lung by increasing the area pressure and then randomized them to two of groups, both groups on a high-frequency oscillator. The group in yellow, you left a high mean area pressure, so once they recruited the lung, they stabilized the lung. And in the blue group, they reduced the mean area pressure until they reached a PaO2 of 100 milliliters of mercury with 100% of oxygen. So what you have here is both high-frequency ventilation, both a very small tidal volume, but this is with an optimal lung volume, so no atelectasis, and this is with a low lung volume. And they then looked at the pressure-volume relationship of the lung after 7 hours of ventilation. And the pressure-volume relationship gives you a mean area pressure on the x-axis and a volume above FRC on the y-axis. And you can see in yellow, the animals that were ventilated with an optimal lung volume and the oscillator have a very nice pressure-volume relationship that you normally would expect. They also had a group of rabbits that were ventilated conventionally, and you can see there's always almost complete destruction of the normal relationship between pressure and volume. But look at the animals that were on an oscillator with a low tidal volume, but at a low lung volume. You can already see there's a deterioration of the normal pressure-volume relationship. So the message from these animals experiments were that if you want to get lung protection during high-frequency ventilation, you need the small tidal volumes, yes, but you also need to optimize your lung volume. So how do we do this at the bedside in our preterm babies? Well, some have used chest X-rays just to assess lung volume during mechanical ventilation, during high-frequency ventilation. And it's probably not a very optimal way to assess the optimal lung volume during high-frequency ventilation. This is a study done by Ulrich Thome, where he looked at the lung volume measured by a washout technique, and he compared this by measuring the surface area of the chest X-ray. And I indicated in the triangles the babies that were on an oscillator, high-frequency oscillation. And you can see there's actually a very poor correlation between the actual volume measured by the washout technique and the ones that were estimated by the chest X-ray. So a chest X-ray is probably not a very good tool to monitor lung volume during high-frequency ventilation and lung recruitment. And it's also very static. It's a one-moment snapshot. It might be different 10 minutes later. So mainly what clinicians have been using is oxygenation as a sort of an indirect tool to assess lung volume. So how does this work? Here we have one single alveolus, collapse with a very small volume, and here's the capillary running by. Because there's no fresh oxygen coming in there, there's no gas exchange, which means that this blood will stay hypoxic once it runs by the alveolus. This is what we call intrapulmonary right to left shunt. And this is very important. So if we're going to increase the pressure, at a certain point in time, the alveolus will pop open. This is quantal behavior, so it's not slowly opening, it's like it's closed and within a few seconds it opens up. And what you see then is an increase in volume. Now there's fresh air and oxygen coming in, and you have a nice gas exchange at the alveolar capillary interface. This is the optimal ventilation perfusion match. You can imagine that this will increase oxygenation. This process going from collapse to an open up is what we call recruitment. You can increase the pressure even more, and this diameter and the size of the alveolus will increase, volume will increase, but this will not impact the ventilation perfusion match. This is still optimal. This is what we call distension, going from recruited to a more recruited lung. You can increase the pressure even more, and you get what we call overdistension. Now we are compressing the capillary here. This means there's an increase in dead space, because if you have ventilation without perfusion, it's called dead space, which is quite different from the other way around, which is right to left shunt, which is perfusion without gas exchange. This is just one alveolus, so if we have many alveoli or saculi in the lungs of our babies, and they're all not the same degree of illness, some are healthier, some are more sick, and if we start increasing the pressure and measuring the volume that's going in the lung, initially nothing happens, and at a certain point in time we get an increase in lung volume as slowly lung tissue or units are recruited, and there's an increase in lung volume. All the way up there until you reach the total lung capacity, which means that all the alveoli are open now and are fully stretched, and if you increase the pressure even more, you will see hardly any increase in lung volume. This is the typical inflation limb of a pressure-volume relationship. If you look at the percentage of blood that flows to collapsed lung units, it's very high in the beginning, so you have a high shunt fraction. You need a lot of oxygen to get this baby saturated. And as soon as you start to increase and recruit alveoli, you can see the shunt fraction goes down. And theoretically, if you would recruit all the units, you will need no supplemental oxygen to have normal saturations. Now there's an important law, it's called the law of Laplace, which you need to know when you're ventilating a baby. And the law of Laplace says the pressure you need to open up or keep an alveolus open is 2 times the surface tension divided by the radius. So the surface tension, you all know, is the force from the wall to the center of the alveolus with a tendency to collapse. And of course, you have the radius. It's important to realize that if you have a large radius, the pressure is lower to open up or keep an alveolus open because it's below the equation. Which means that if you start off with recruitment, you have a very small radius because the alveolus is collapsed. But if you open up the alveolus, the radius will rapidly increase, which means that the pressure you need to stabilize the alveolus once it's open is much lower. This means that if you walked all the way up there, recruiting the lung, and you start decreasing the pressure, initially you will not lose that much lung volume. Because of Laplace, the radius is much higher and you need less pressure to stabilize the lung. But at a certain point in time, you will lose lung volume and you get de-recruitment, and then again, you will have a problem with oxygenation. So the shunt fraction stays low much longer than during inspiration, but eventually increases and leading up to hypoxia. So just to visualize this is a piglet lung, surfactant deficient. We go up with the pressure, nothing happens. Here we see that there is lung recruitment, and in the end we have a fully recruited lung. And now we go back stepwise with the same pressures until we have collapse again. And this is what we're talking about. This is, at the same identical airway pressure, a completely different lung volume. depending on if you first recruited the lung or just stayed up here. This is where we want to ventilate our babies, on the optimal deflation limb where there's much more stability and a much better compliance. So how does this translate to babies with RDS? It's very nice theory, physiology, you need to understand this, but is it actually applicable to our babies with RDS? And this is a question we also asked ourselves, and we tried to answer with a really cool machine called electrical impedance tomography. Now, this is a machine that measures changes in impedance, which is a reflection of the changes in aeration in the lung. You put 16 electrodes across the thorax like this. There's a current running by between the electrodes, and it measures the impedance with the other electrodes. And you get these kind of functional pictures. It's sort of a slice through the thorax showing you the heart and the right lung and the left lung. You can also measure the change. It is a pressure change followed by a total impedance change, and you can quantify the increase in aeration after each step you make with the high-frequency oscillator. And we did this in a group of 15 babies, RDS babies, 28 weeks, less than 1,000 grams, who were intubated in the first 24 hours. And we stepwise recruited the lung using oxygenation, but we also measured the changes in aeration, because oxygenation is an indirect measure of lung volume. And what you can see is that indeed in these babies, preterm infants with RDS, in the first 24 hours of life, you have what we call a pressure-volume relationship, and you have a difference between the inflation and deflation limb. You have lung hysteresis, meaning that at the same pressure, you can get a different lung volume depending on if you recruited the lung. And this is something that we should use in clinical practice. It means that once you recruited the lung, you have to back down with the pressure, making sure you're on the deflation limb of the pressure-volume relationship. So how do we do this in Amsterdam, where we primarily ventilate all our babies when they have pulmonary problems with the oscillator? We have time here on the x-axis and airway pressure on the y-axis. We start relatively low with the pressures, and then we stepwise increase the pressure and see what happens with oxygenation. If you recruit the lung, or part of the lung, with an increase in pressure, your VQ match will improve, your shunt fraction will decrease, your oxygenation will go up, and you can reduce or wean your FiO2 stepwise. And in steps of 2 centimeters of water every few minutes, we go up, and we defined arbitrarily in our unit that an optimal lung volume is a lung volume where you need less or equal than 25% of oxygen. Once we're up there, we've opened up the lung, but now we have to take advantage of Laplace. We have to back down with the pressure. So we stepwise start decreasing the pressure until we see a drop in oxygenation, telling us that some parts of the lung are collapsing again. Increased shunt fraction, lower oxygenation. We know we have to walk all the way up there again to the top of the inflation limb, so we increase the pressure once more and then set the optimal pressure 2 centimeters of water below the closing pressure. In this way, we individually, for each baby, titrate the optimal pressure that this baby needs and recruit the lung for each individual baby. Sometimes you need high pressure, sometimes you need lower pressure, depending on the severity of lung disease. Why wait a couple of minutes? Well, we also looked at this. If you take a pressure step with the impedance tomography, it takes about 80 seconds stabilization time before your lung volume is increased in response to this pressure step. So we prospectively collected the data on a large group of babies where we applied this strategy. So we intubate the baby, and before giving surfactant, we recruit the lung. We started off at low pressures. At that point in time, you need a high oxygen need, 70%, because there's a lot of atelectasis. The opening pressure, so the mean airway pressure you need to recruit the lung in this group of babies, was about 20, 21. And it showed you that you could reduce the FiO2 to 24%. The closing pressure was 12, and the optimal pressure was 14. So this way we were able to recruit in most babies the lung, and in most babies we were able to get an FiO2 at 25% or below. Not always. There are some patients that react differently, but in a majority of patients you can recruit the lung and get these FiO2s. Then we give surfactant, and once you give surfactant, you can reduce the pressure because now the surface tension in the Laplace equation is getting lower. So surfactant will stabilize your lung and allow you to decrease the pressures to 9 centimeters of water in this cohort, leaving almost no supplemental oxygen. What about side effects? We look at mean arterial blood pressure and heart rate in blue and yellow during the different stages, going from 8 to 21 to 12 to 14. We didn't see any problem on blood pressure and heart rate. We also looked at systemic flows along the heart, a slight drop in right ventricular output, but no major differences during the recruitment procedures. So if you individualize this recruitment procedure to what the baby needs, you will not find any hemodynamic problems. Still, all nice physiology, it seems to work, but if you look at the randomized controlled trials that have been conducted over the last 20, 30 years, you see there might be a reduction of CLD in the babies on a high-frequency oscillator, but it's an inconsistent effect across trials. Some trials found no difference in BPD, and other trials found a reduction in BPD. Now, there's two ways to approach this. You can say, doesn't work. Forget about high-frequency ventilation. Let's move on to the next one. Or you can try to learn from these trials. Why do some trials find an effect, and why do other trials do not find an effect? So for me, the most important comparison is between these two trials. The Courtney trial, so it's a US trial where they randomized preterm babies to high-frequency ventilation or conventional ventilation, and the Johnson trial, the UCOS trial, where it is a similar trial. And despite the fact that they were both done in the same era, they found opposite results. The Courtney trial found that high frequency resulted in early extubation, and they found less death or BPD with a number needed to treat of 10, which to me is a clinical relevant outcome. No adverse effects. On the other hand, the Johnson trial, no differences in ventilation time, no differences in death or BPD. Again, no adverse effects because we were always concerned on IVH or air leaks. They didn't find any in these trials. So why are these two trials having different results? Let's take a closer look at these trials. They both included a fairly amount of babies, 500 in the Courtney trial, 800 in the Johnson trial. Both very preterm babies, 26 weeks. That's the kind of babies we are treating in our unit also. However, there was a difference in the characteristics of the babies. In the Courtney trial, they only included babies with severe RDS. So a baby was born, put on conventional ventilation, got surfactant early on in the first hour, and if the FiO2 didn't come down to extubation settings, then the babies were recruited in the trial. In the Johnson trial, all babies were randomized, whether you had RDS or transitional problems for intubation and ventilation, whether you had severe RDS or mild RDS, it didn't matter. All babies were put in the trial. So there's a big difference there. There was a difference in experience. The Courtney trial really had a sort of a pilot phase where all the sites that participated in the trial had to prove that they were experienced in using high-frequency ventilation. And this was much less in the UCOS trials. So there's a difference in how they approached and their experience level on high-frequency ventilation. There was a difference in the machines they used. The Courtney trial only used the Sensomatics, and in the Johnson trial, they had all kinds of different ventilators, hybrid ventilators and Sensomatics. And another important thing was, in the Courtney trial, you stayed on the assigned mode of ventilation until the time that you were transferred to another hospital, which means if you were intubated in the beginning, you got extubated again, and you needed re-intubation at week 2, you again got the assigned ventilation mode. So the babies remained on high frequency oscillation throughout their admission. And this was not the case in the Johnson trial. They were allowed to switch to conventional within the first 5 days of life. I mean, if you look at the trial, most of the babies that were in the oscillation arm already switched to conventional at 72 hours of age. And this is probably because they were not that experienced and familiar with high frequency oscillation. So to me, this tells a story. I think it's important to realize that high frequency oscillation is not the golden bullet for every baby, but it might have a benefit for those babies who actually have severe RDS. It seems to be important to be experienced, to know what you're doing, to know the physiology, and it's important to keep the babies on the oscillator from start to end. And this might give you a clinical relevant reduction in death or BPD. So what about high frequency oscillation and other causes of respiratory failure? Well, I've a list here from babies that have problems, pulmonary problems that might be candidates for high frequency oscillation. It's a long list. You probably recognize it. Some of you might use the oscillator in one of these diagnoses. It's important if you want to replicate what they found with the RDS patients to this group of patients that you ask yourself some very important physiological questions. Is the lung disease I'm treating this baby for with high frequency, is it recruitable lung volume? In some cases it is. There's maybe not surfactant deficiency, but surfactant dysfunction, like with meconium aspiration, chronic lung disease, pneumonia, ARDS. Might be there's a loss of lung volume because of an abdominal distension, pushing the diaphragm up and giving you a low lung volume. Maybe you're more afraid of the risk of overdistension. And is this an important reason for you to start with high-frequency ventilation, like with lung hypoplasia or babies with air leak syndrome? Always good to know if there's pulmonary hypertension present, because if there's pulmonary hypertension with extrapulmonary right-to-left shunt, this will compromise oxygenation as a tool to guide your lung recruitment. So before using the oscillator, ask yourself these important questions. What is the aim? What is the pathophysiology of the disease? And what am I aiming for when putting this baby on an oscillator? Having said that, especially in the recruitable lung diseases, I think that the basic concepts that we've shown with the RDS babies also apply to babies with pneumonia or other kinds of lung disease. And this is a study done by the Melbourne group, David Tingay's group, where they had 12 babies, term babies with different kind of disease, pneumonia, chronic lung disease, who were already on an oscillator. And this is the point where these babies were on at the time of the study. And what they did is they increased the pressure stepwise, looking at oxygenation, trying to get the optimal oxygenation, and then they moved back again until they saw deterioration oxygenation. So the same principles we explained to you with the RDS babies. And what you can see that even in these babies, there is again sort of a hysteresis present. So it means that the lung hysteresis that we showed you with the RDS baby is also present in the more mature baby with more heterogeneous lung disease. However, RDS is a relatively homogeneous disease, and most of these babies have heterogeneous lung disease. This is an MRI scan showing you the water content, but you can clearly see that it's a heterogeneous lung disease with more of the water showing in the dorsal dependent lung units compared to the non-dependent anterior lung units. And this is something that we have to bear in mind. If you want to translate lung recruitment to these babies, there is a difference. You probably need some higher pressures to recruit and stabilize the lungs of these bigger babies with heterogeneous lung disease. They have a longer time constant, which means that if you increase the pressure, it will take a longer time for the lung volume to change as a response to this pressure. I showed you that with the RDS babies, we take pressure steps every 2 to 3 minutes. In our unit, we sometimes wait 45 minutes after each bigger step often, to watch for a fully recruiting effect of the pressure step. So you have to be more patient, going up and going down. You sometimes need lower frequencies. You probably should accept a relatively higher FiO2 to define the optimal lung volume. And you probably need to extubate from higher settings. You will not be able to wean down in this heterogeneous lung disease to, let's say, 8 or 6 centimeters of water before you can extubate. You can probably extubate this baby somewhere between 10 and 15 mean airway pressure. So if you have pulmonary hypertension, again, it's like I said, oxygenation is compromised as a marker of lung volume. So the best you probably could do is use the preductal SpO2 as your marker for oxygenation, and maybe fix the FiO2 at a higher level and then start titrating the pressure using the PaO2. If you have pneumonia or meconium aspiration, parts of the lung will not be recruitable, either because it's blocked by meconium or there's debris inside and you have a diffusion problem. So you will not be able to reach lower FiO2s of 30-35%. This is something you have to accept and know that you probably have higher FiO2s to target. And if a baby has NEC with a large abdominal distension, even though that the lungs are pretty healthy in these babies, you still need some higher pressures to push down the diaphragm in order to get the lung at an optimal lung volume. And finally, if you're using it at lung hyperplasia, you often do not need to recruit the lung. So you're probably just aiming at avoiding lung overdistension by using the very small pressure amplitudes and not going up with the pressures or the mean airway pressure that high. What about some evidence that high frequency might play a role? It's very limited. It's mainly studies that looked at babies that were pretty sick, then randomized them to conventional or high frequency, so continuing on conventional, switching to high frequency, then depending on their success, switching back and forth to the other modality. And in general, you can see that high frequency had a more success rate of restoring normal gas exchange. Same is true in combined with inhaled nitric oxide. Again, very sick patients, actually already candidates for inhaled nitric oxide. And if you switch them first to high frequency instead of directly to ENO, you can see there is a response. And if you switch them back and forth, you can see that high frequency gives you a better response in terms of oxygenation. And also it's a better response combined with inhaled nitric oxide. But that's about it if you're looking at the term babies and with heterogeneous lung disease and the role of high frequency ventilation. So to summarize this, the animal studies have clearly shown that high frequency is lung protective, but only if combined with the optimal lung volume strategy. And oxygenation for the RDS patient seems to be a pretty decent bedside tool to recruit the lung. Higher frequency probably can reduce BPD, but only in the babies with severe RDS. And I think that it's important that the concept of open lung ventilation also applied to other causes of acute respiratory failure, but we don't have any clinical trials to support this. Okay, let's switch to positive pressure ventilation. If you're not using high frequency ventilation, how can you be as lung protective as possible using, for instance, time cycle pressure limited ventilation? Well, we should probably aim at reducing the tidal volume, keeping it somewhere within a target between 4 and 7 mL per kilo. I'm not sure, I think that 4 to 7 mL is sort of a physiological, spontaneous tidal volume, but we don't know if it is the right tidal volume in babies that are actually on a ventilator. If you look at the literature, there's only one study, one small study, 30 patients from Gianluca Lista, looking at different tidal volumes using a volume guarantee. They randomized these babies to a volume of 5 mL per kilo versus 3 mL per kilo. And what they could show, surprisingly, is that the lower tidal volume actually increased pulmonary inflammation. So it's really not something you would expect. So too low a tidal volume might not be the way to go. On the other hand, they only used a PEEP of 3 to 4. And like I told you, if you have very low PEEPs and then again, at very low tidal volumes, you can induce atelectasis in these kinds of lungs. We talked about this morning stabilizing the tidal volume, avoiding too high or too low. And I showed you this morning that there seems to be a signal out there by stabilizing the tidal volume, you will be able to reduce death or BPD in your babies with RDS. But what about reducing atelectasis by lung recruitment or stabilizing lung at the optimal PEEP level? Again, neonatologists, at least as far as I know, are not keen on applying high peak pressures and high levels of PEEP during conventional ventilation. Animal experiments have shown that it is possible to recruit the lung and stabilize the lung also with normal positive pressure ventilation. We did a series of studies in piglets with an RDS model by saline washout. We used a meconium aspiration model and a GBS pneumonia model. And we randomized the piglets in 3 groups, sort of a conventional settings with 24/5, 30 to 60 per minute frequency, and an oxygenation-guided open lung recruitment strategy using positive pressure ventilation and the oscillator. And you increase the peak pressure recruiting the lung, and you increase the PEEP to stabilize the lung. And in the end, you get these kind of settings, which are very unusual for normal clinical practice, where you have a PEEP of 12, a peak of 19, and a high rate of 120. And of course, we have the oscillator. And if you look at the lung injury scores, the control group, open lung positive pressure, open lung high frequency, and conventional ventilation, using either a meconium aspiration model or a respiratory distress model, you can see that both the open lung models have less lung injury compared to the conventional ones. And the same is true, we looked at a GBS model, GBS pneumonia, and we looked at the translocation of bacteria from the lung into the systemic circulation. You can see in white here are the number of animals on conventional ventilation, and you can see that the ones with negative blood cultures rapidly decrease over time. Once if you have a baby with an optimal lung volume strategy using positive pressure ventilation, you can see the translocation is much less. And the main message here is that there's no difference between the oscillator and the positive pressure ventilator. Again, emphasizing that it's the strategy that's most important and not the ventilation modality that you use to apply this strategy. So what about human studies in babies? I found this study by Marty Kessler where he looked at 80 babies, term babies on ECMO. And during ECMO, he ventilated these babies either with a PEEP of 3 to 5 or 13 to 15 centimeters of water. And what he could show that they had an improved lung function, the babies who were on a high PEEP and had a shorter run on the ECMO, but there were no long-term outcome data presented. And there's only one study that looked at recruitment with conventional ventilation. It is again by Gianluca Lista. 20 babies, 25 weekers, 750 grams. They were already treated with surfactant for RDS. They were on assist control ventilation, volume guaranteed, 6 mL per kilo. And they did a recruitment versus a no recruitment in the first 3 hours of life. And it looks something like this. You can see here in the white line the FiO2. In the black line you can see the SpO2. And here you can see the PEEPs that he applied. So what he did, he fixed the tidal volume, and at the beginning there was a high FiO2 with a low saturation. He stepwise got up to 7. This resulted in a drop in FiO2 and an optimization of saturation. He then stepwise went down until he saw a drop in oxygenation, indicating there was collapse, and then he optimized the lung volume at around 5 centimeters of water, getting normal saturations with a low FiO2. But this is the only paper I know of that actually looked at lung recruitment, and this is already after surfactant treatment, so the pressures are relatively low. So to summarize this, the animal models have shown that tidal volume reduction, recruitment, and higher PEEP levels are lung protective, but there are no randomized control trials that actually have shown a clinical relevant benefit or have ever been conducted to show a benefit. The only thing that's been beneficial so far is stabilizing the tidal volume with volume targeted ventilation. So, recommendations for practice. Again, knowledge of normal pulmonary physiology is essential if you start ventilating your babies. Knowledge of the pathophysiology of the disease. What kind of disease is this? Is this an overdistension disease? Is this a recruitable lung disease? You need to know before you can apply the right intervention. You need to know the concepts of lung protection before you start. You need to know the ventilator characteristics. I said this morning, and it's also applicable if you are trying to be lung protective in a strategy. You have to understand your ventilator. I think the basic thing is we should minimize lung overdistension as much as possible. So I would go for a tidal volume below 7 mL per kilo, and if possible, add volume guarantee to stabilize it. And avoid atelectasis by using sufficient PEEP. So I'm not telling you to go up to PEEPs of 10 or 12, but if you look at some of the PEEPs that people are using, it's usually 4 or 5, and they don't change it anymore. So go up with the PEEP depending on the X-ray and the amount of oxygen that a baby needs. And it's no problem to go up to 6 or 7 with PEEP to stabilize the lung in our babies. Minimize atelectasis. Recruitment, I would only use at this point in time with a high-frequency oscillator and not with a conventional machine. And you stabilize the lung as much as possible. And if you want to do a true open lung ventilation strategy in RDS babies, I would recommend to use an oscillator and not a positive pressure ventilator. What are the remaining questions for research? What is the optimal tidal volume PEEP? We still don't know. We are treating our babies with a treatment, and we don't know if 4 is better than 8 or 5 is better than 10. I think we should figure out what the optimal settings are. And the same goes for PEEP. We don't know if conventional lung recruitment is lung protective. If there is indeed no difference between open lung applied with a conventional ventilator or with an oscillator. And we need to know which patients will benefit most. As I showed you with the high-frequency trials, it's not a problem to treat all your babies with an oscillator or lung recruitment, but at the end, only a few of them will benefit from this strategy. And we need to find out which babies need lung recruitment and which babies are fine with just a relatively low PEEP and a normal tidal volume. And the other interesting thing for me is we have been focusing on those babies that are born in the first 72 hours of life. Most of the trials done on ventilation are in the RDS period. And as we discussed during these recent days, many of our babies are now managed quite fine on nasal CPAP in those early days, but they get into trouble in the second week of life. Apnea, sepsis, and then you start ventilating them, and then slowly they deteriorate and you get a baby with BPD. So maybe we should start thinking about what the strategy would be in those babies with the inflamed lungs, with CLD, with surfactant deficiency. Maybe we should target these babies in future trials, trying to be lung protective or not trying to get the optimal tidal volume. Might be that we're losing the battle in the second week instead of in the first week. I'd like to acknowledge all of my co-workers in Amsterdam and Rotterdam and abroad. I'd like to thank you for your attention, and I'm welcome to answer your questions. Ooh, yes.
If I understand correctly, you in the acute RDS, you firstly use oscillation and then give the surfactant.
Right.
And what about the different strategy? If you firstly give the surfactant and then use oscillation?
Yeah. That's a good question. I think it depends on the strategy of surfactant treatment in your unit. So if you are prophylactically giving surfactant in the delivery room, then the surfactant is already in there. We as a unit give rescue treatment, and I think the evidence suggests that it's okay to wait, put a baby on nasal CPAP, and then most babies get intubated in the hours after that, so it's mainly rescue treatment that we're using. The problem we have, at least in our units, we want to know the position of the endotracheal tube before giving surfactant, which means we need an X-ray, which means that if a baby is intubated, it stays on the ventilator for some time, 10 minutes before we get the X-ray, clearing that the tube is in the right position, and then we give surfactant. In these 10 minutes, it's not uncommon that babies have 50, 60% FiO2, and you give them these 5, 6, 7 mLs, relatively high pressure ventilation, and we know that just for these 10 minutes, it could be that you're already inducing lung injury. So what we try to do in our unit is don't intubate in the delivery room, get the baby on the ward, see how he does. If he is failing nasal CPAP, intubate and immediately start on the oscillator. Recruit the lung, be a lung protector from the time on. And once we got the lung recruited, then the X-ray is taken, and then we give surfactant after recruitment of the lung. It's also more practical, because if you put in surfactant, you will change the surface tension in the Laplace equation, and then you start turning the pressure, and you will increase the radius. And it's a really dynamic interaction, so the pressure you give at minute 1 will be appropriate, but when the surfactant comes in there, it might be too high at that point in time because the lung is more compliant. So to keep it practical for all the staff members and the registers to apply this strategy, we've decided to first recruit the lung and then give surfactant, wean down, and extubate within the 6-12 hours after recruitment and surfactant treatment.
And how long it takes to recruit the lungs?
That's a good question. If you're an experienced hand, it probably takes you about 20 minutes to do the first recruitment round. And the X-ray, you can phone in halfway, so you get the X-ray, and then you give surfactant and wean down the pressures. And we are going to write a paper on this just to give some indication on how much time. It's more time-consuming than putting a baby on a conventional ventilator, 25/5, and then go for coffee until the X-ray is there, and then give surfactant, and then wean down the pressure. So you need some more attention. But I think ventilation is a dynamic treatment. The lung is changing all the time, so it's something you need to monitor and adjust.
Thanks. Do you have any information on whether or not there are alterations in the incidence or severity of things like PVL or IVH based on the mode of ventilation?
So you mean in the trials or in my own experience? Well, my own experience is, of course, biased because this is what we do. In the study we did, we didn't find any increase in IVH or air leaks. And I must say it's very uncommon in our unit to have these air leaks. At the time when you start recruitment and you get an air leak, it's very uncommon. Most babies already have an air leak when they get it on the oscillator. I can't remember that an air leak was induced by the high pressures during the lung recruitment procedure. And if you look at the trials, the recent trials by Courtney and Yuko's trial, they didn't find any difference between conventional and high-frequency ventilation in terms of IVH, PVL, or air leaks. Okay. Yes?
And do you recommend for how long the baby should be on this and the higher PEEP, even if the baby is breathing by their own and don't need any support? It should be stand on the CPAP, on the PEEP.
You mean during conventional ventilation or during high-frequency ventilation?
During the non-invasive ventilation.
Non-invasive.
Mm-hmm.
So how long the baby should be on?
Yes.
On the CPAP pressure?
Yeah.
You mean weaning down CPAP pressure to?
No, to avoiding atelectasis. It could happen even if the baby, for example, we use non-invasive ventilation, sure, and then we stop because the baby is breathing, and it could be the second step could be the atelectasis. Mm-hmm. So we should stand for some, I don't know, weeks with the PEEP or not? Do you understand my question?
Not completely. So if the baby's a non-invasive support with CPAP,
Yes.
you mean?
Yes.
And then it's doing fine on 6 centimeters of water, and you're wondering if we should keep it on 6 or...
For how long?
Okay. I don't know. It's a really good question, and I think there are no trials that actually looked at this. There are some trials that looked at switching from CPAP on and off versus completely stopping CPAP. But how you should wean down. I guess the important thing is that also in the non-invasive support, the FIO2 will give you information on if there's atelectasis. Because if there's atelectasis, you will get an increase in FIO2 because there's intrapulmonary shunt, which is also possible during non-invasive support. So if the FIO2 is low, you might try to wean down stepwise the pressure. You also should monitor the breathing of the baby, because it might be that if you try to reduce the pressure and lung volume tends to be too low, that the baby starts increasing its respiratory rate to keep the lung volume up there. And this is something you don't want to happen, so then you should increase again. So there are several parameters you could look at when weaning down the CPAP pressure, but nobody actually knows at what pace or you can wean down. It's a trial and error thing, I guess. It's a difficult thing to look at in randomized trials, I guess, also.
And some question about mass approach to the mass treatment. Do you practice a lavage or not? And I have a second question. If you do or not, can we use instead of surfactant to do lavage normal saline as an alternative for development country? Thank you.
So, starting with your second question, no, you should not use saline. There are some data out there that it's not going to be beneficial or even detrimental to your patient's lung condition. So I would not use just saline to wash out the meconium. I don't think it's going to come out with saline that much. And in terms of lavage with low concentration surfactant in the lavage fluid, I know that Peter Dargeville did a trial on this, and there were some effects on ECMO indications and stuff like that. But okay, so Andreas is coming back to that later on. But we don't use it. We give bolus surfactant in our babies.
I ask about this alternative because what will be worst, the meconium in the lungs or the saline and the lungs without the meconium and chemical pneumonia? That's what that was the goal, actually.
Yeah, I think it's a good question, but I would leave the meconium in there and not start washing out. But yes.
I'm afraid this is a tough question, but there are no more coffee breaks to give it.
Okay.
Yes, well, so I think that you're very much right in that it's a vulnerable period when the child is on its way to developing BPD at 2 to 3 weeks, lots of inflammation and so on. And I think that probably quite a big amount of violence against the lungs is happening at that times when the children make all that big desaturations. Have you any suggestions on how to do that the kindest possible way? I think we can increase oxygen and we can try to give prolonged inspirations and even mask ventilations with high pressures. Nothing really gentle.
So you mean when there are non-invasive support?
On ventilation.
On ventilation.
Could be oscillation or could be conventional, but you see the drops in.
Right. So I think it's a very good question, and I think there is a difference between oscillation and conventional, because oscillation to me is CPAP with a wiggle, which means that the patient is allowed to breathe on top of the mean air pressure, and there's a wiggle the amplitude. So the interaction between in and out, normal tidal ventilation, is not as an important factor during high-frequency ventilation as it is during conventional ventilation, because then you have these asynchrony, these interaction that are not optimal if these babies are fighting the ventilator and they're breathing in and out, and the ventilator isn't capable of following what the baby wants. The only thing I can recommend is try to get ventilation mode that is allowing the baby to control breathing as much as possible. So for instance, CPAP pressure support, in some babies that are restless and are fighting, if you give them pre-CPAP pressure support, they are more in control, and they will not have these desaturations as you normally see with these, especially the BPD babies, who sometimes, you know, get these rigid thoraxes, chest walls, and then the pressure doesn't come in. Volume guarantee is another one, because if you guarantee the volume and allow the pressures to go up, it will sort of automatically adjust for the compliance and the resistance of the baby, and this will probably give you a faster response in the buildup of pressure than you can do manually if you're just on TCPL. So volume guarantee or pressure support, these are the two modes that might help in invasive ventilation if the baby is restless and changing a lot with saturations.
In the severe BPD, we have a problem with air trapping. And what do you think about the strategy to lower mean airway pressure as much as possible, increasing at the same time FiO2 to provoke the over-distended areas to collapse?
Okay, so I have to think about this. So you have a heterogeneous lung with overinflation and atelectasis, and you want to lower the mean airway pressure, allowing the lung to collapse?
The over-distended areas only, to something like that. To empty these over-distended areas to...
Yes. Well, it's...
What do you think about it?
I wouldn't have a straightforward answer for that, because it's a trade-off between letting the lung get atelectatic versus the overdistension. So I would extubate the baby as soon as possible, as I was you.
Because you said that not homogeneous lung may require higher pressure.
Yes.
But we wonder if we have already over-distended areas, doesn't it provoke the air leak?
Sure. The problem is that if you have heterogeneous lung disease, it's difficult to find the one pressure that does not overdistend the more healthy ones against the sicker ones. So it's always a trade-off. This is life, you know. There's no way of getting the ideal pressure and not overdistending. It's heterogeneous lung disease. On the other hand, you have to answer the question: what is causing the overdistension? Is it airway collapse? And then probably increasing the pressure will give you a better emptying of those lung units. So as far as I'm concerned, I would not go with the pressures, especially during high frequency, to the lower pressures, leading to airway collapse, especially if you have active expiration. I would maintain these babies in the higher levels, but accept a little bit more FiO2 and not trying to recruit all the way up there to get the FiO2 down to 25 or 30%.
What do you think about a strategy of having a low frequency for these babies? There's some enthusiasm in Melbourne for that way, and the alternative of jet ventilation and sort of
sure.
The concept of active exhalation being a good thing for these babies with heterogeneous, and particularly for the overdistended things, have a low frequency time to empty.
Yeah.
Anything in that?
No, you're right. So if you're on the oscillator, there are some units that lower the frequency, allowing for more time to exhale, or switch to jet ventilation. We don't have any experience with jet ventilation. We don't have it in Europe. It's not something we can use unless it's for research tool only. And there was a difference between the approach. We hardly use below 10 frequency. Sometimes we go to 8. But in Melbourne, they are used to going to 8 or 6, and they have some good results out there. I'm not sure if it's completely teased out what the best way is, because if you lower the frequency, you will increase your tidal volume. So it's again a trade-off between you want to get the lowest tidal volume, trying to reduce regional overdistension. On the other hand, you want to have sufficient time to get the air out there. So it's trial and error, and there's no cookbook here.
The tidal volume in oscillation is not so dangerous because we should remember that the lung stays, the lung volume is not changed. So why be afraid of bigger tidal volume in oscillation?
I think it's a good comment. If you compare tidal volumes with a fully recruited lung, you don't have this collapsing and reopening of the lung units, and you don't have the distribution. But if you're talking about heterogeneous lung, where some parts are still empty or collapsed and some are open, and you lower your frequency, you can get up to higher tidal volumes, 3-4 mLs per kilo, if you go down with the frequency. And again, then you will have the same heterogeneity, and the volume will slowly progress to a more tidal ventilation once you reduce your frequency. So there is a balance between that, and we don't exactly know what the optimal balance is. Okay? All right. Thank you.